This is the valgus and the varus test. It's going to test the UCL and the LCL of our patient's elbow. So basically what we'll do is we'll have our patient lying right here. I'm going to stabilize her humerus right here. And I'll apply valgus force distally. And so when we apply here, if there's increased laxity when compared to the uninvolved side, then it would be a positive test for lack of integrity of the UCL. And now we'll switch our force, again, stabilizing the humerus right here, and we'll apply our varus force. And if there's increased laxity when compared with the uninvolved side, then it will be a positive test for LCL compromise. This is the milking maneuver, and it's another way to test for the integrity of the UCL. So how we're going to do this is we'll have our patient sitting right here with her elbow flexed at 90 degrees. Now I'm going to stabilize her distal humerus right here, and then I'm going to pull her thumb like I'm milking a cow, and I'm going to pull her outwards like here, which in turn creates a valgus force at her elbow, specifically at the UCL. And if we notice a difference in laxity from the involved to the uninvolved side, then it would be a positive test for UCL compromise. All right, so this is the moving valgus stress test, and so basically it's another way to check for the UCL integrity and involvement with our patient's pain complaint. So basically what we're going to do is we'll start with our patient with her arm abducted right here, and then full flexion, and then I'm going to apply a valgus force at her elbow, and then I'm going to bring her into extension. And if her pain is reproduced that she came here for within 70 to 120 degrees of elbow flexion, then it would be a positive finding for this test. All right, so if our patient comes in with signs and symptoms of lateral epicondylitis, then we should do this 3-test sequence called the Cosen's test, the Mills test, and the Mosby's test. So the first test we start with is the Cosen's test, where I'll ask my patient to make a fist like so with a bent elbow, and then to point her knuckles into wrist extension towards the roof. Now I'm going to apply resistance to her, and I'm trying to see if that reproduces her pain in her lateral epicondyle area. And if that's negative, then I'll ask her to, or then whether it's positive or negative, I'm going to ask her to keep her fist made right here, like so. I'm going to bring her into elbow extension, and now I'm going to possibly take her into wrist flexion. And if this, looking to see again if this reproduces pain with her wrist extensors on stretch. And then finally, the last test what we're going to do is I'll just have my patient hold her arm, have her arm right here, and then she's going to have resisted middle finger extension, and I'm going to apply my force distal to her PIP. So again, I apply my force right here, and I'm looking to see if it reproduces her pain at her lateral epicondyle. Reproduction of pain would be positive for the test. A test that you would do if you suspect a tear of the biceps would be the bicep squeeze test. So what we'll do is we'll have our patient rest their arm on their lap like so, and then we'll come from behind and squeeze the bicep, and we're looking to see if there's any supination in the forearm. So here we go. And then a positive test would be no supination in the forearm, indicating a tear of the biceps. All right. Now for suspecting our patient came here with owner problems in her cubital tunnel, then what we can do to test to see if that is the issue is the elbow flexion test. So basically what we'll do is we'll start with our arms by our side like here, and we'll flex our elbow and extend our wrist. And we'll hold this position for 3 minutes, looking to see if we produce the symptoms which we came here for. And then if we're not reproducing the symptoms, we can further stress the ulnar nerve by abducting our shoulders like so, which is just further complicating the ulnar nerve. And that would be a positive test if it reproduced the symptoms, like her. So this is the Tinel sign. We're going to do this if our patient is complaining signs and symptoms which correlate with ulnar nerve problems at her cubital tunnel. So basically what we'll do is we'll take her arm right here. I'm going to passively hold it so she's not like under any tension. And then I'm going to tap at her cubital tunnel at her ulnar nerve. Okay. And then I found it in 1, but you can use up to 6 if you need it to reproduce the patient's complaints that she came here for. That would be a positive test. All right, so this is the pinch grip test, also known as the teardrop test, and also known as the OK test. So basically what we're doing is if we think our patient's anterior interosseous nerve is involved, then we can do this test to find out for sure. So what we'll do is we'll have our patient make an OK sign like here, having our tips of our index finger and our thumb come right up to each other. And if for no reason we can't hold that and it starts to go more towards the pads of our fingers, then this would be a positive test indicating that the anterior interosseous nerve is involved. All right, so this is the Watson test, also known as the scaphoid shift test. So basically what I'm going to do is I'll have my patient with her elbow bent like so, and then I'm going to bring her into ulnar deviation and some extension. I'll have my thumb on her scaphoid right here, and now I'm going to bring her into some flexion and radial deviation, and I'm looking to feel if there's any clunkiness or instability of her scaphoid. And if I feel that, then that would be a positive test for instability of her scaphoid, hence the scaphoid shift test. So this is the scapholunate and the lunate tricleteral shear test. These shear tests are done to assess the integrity of the scapholunate ligament and the lunotricleteral ligament, because these ligaments are the big troublemakers for carpal instability if they're compromised. So how we're going to find the lunate is we'll come down our patient's third metacarpal right here. We're going to come to the capitate. Now we're going to come ulnarly and proximally to it to get to our lunate. Then I'll ask my patient to extend her thumb right here so I find her anatomical snuff box, and I'll come just on top of it like so. Now I'll apply my scapholunate shearing, and I'm looking to find excessive instability or just extra movement when compared to her uninvolved side. If so, that would be positive for the scapholunate shear test. Now for lunotricleteral, I'm going to switch my thumbs on the lunate so I still have my placeholder. I'm going to find my patient's pisiform right here, and then because the pisiform sits on top of the tricleterum, I'm going to apply my shear between the lunate and the pisiform. Again, looking to see if there's excessive instability, excessive movement when I'm comparing her involved side to her uninvolved side. And if there is that present, then it would be a positive test for lunotricleteral shear. All right, so this is the Lichtman test, also known as the mid-carpal shift. We're going to do this to assess for any excessive movement between the proximal and distal carpal rows of the hand. So what we're going to do is I'll have my patient, we're going to start in radial deviation like here. I'm going to come down her third MC to her capitate right here. And now I'm going to, with securing her forearm, I'm going to hold her capitate like so. And then I'm going to actually load her and bring her into ulnar deviation right here. And if I feel her proximal carpal row jump at me, if I feel any instability, if I feel any like clicking and excessive movement in between the rows, then it would be positive test. This is the Shuck test, also known as the finger extension test, and it's another way to test for carpal instability in our hand. So basically what we got is our patient has her forearm on the table with her wrist slightly off the edge to allow for some slight wrist flexion and some slight finger flexion. Now we're gonna come a little bit distally, just slight distally to her MCP joint like so. And then we're gonna provide resistance, and I'm asking to press against my finger so there's resisted finger extension. And then we're looking to reproduce pain in her hand, and if so, then it will be a positive test for carpal instability. A way to test the integrity of my patient's thumb and both the bone and the joint itself, is the thumb CMC grind test. So what I'm going to do is I'm going to first secure her distal radial ulnar joint and her carpal bones like so. I'm going to take her thumb and I'm going to apply an axial loading, which is the compression force, looking to see if there's any pain with this. And then I'm going to grind it by taking it through some circumduction. And when I'm doing this, on top of the pain that could have been felt with the compression. I'm also looking for any clunking or grinding, and if so, then it would be a positive test. To assess the integrity of my patient's distal radial ulnar joint, we're going to do two tests right here. So the first one is called the piano key test, and so we're going to do this with our patient resting her forearm in pronation like so, flat against the table. I'm going to come and press on her distal ulna like a piano key, and I'm looking for excessive movement when compared to the uninvolved side, as well as reproduction of the pain which she came here for. The other way you can do this is a radial ulnar joint stress test. So I'll bring my patient's hand up like here. I'm going to stabilize her distal radius, and I'm going to apply an anterior posterior force at her distal ulna like here. And again, I'm looking for excessive movement when compared with the uninvolved side, as well as reproduction of the pain she came here for, and if so, it would be a positive test. So this is the UCL stress test for the thumb. So what I'm going to do is I'm going to stabilize my patient at her CMC joint of her thumb, as well as to bring her down into flexion. And then with her inflection, I am going to apply a valgus force to stress her UCL of her thumb. And if this I'm looking to see if this reproduces the pain which she came here for, as well as I'm trying to see if I get more than 30 degrees of excessive movement. And if so, then it would be a positive test for the UCL stress test of her thumb. So if our patient has pain on the ulnar side of her forearm and wrist, then we can check for to see if the TFCC is contributing to this. So what we'll do is we'll do the ulnar meniscal tricleteral dorsal glide. So I'll have our patient with her arm like so, and I'm going to come to my patient's distal ulna and her pisiform. And so I got my fingers like so, and I'm going to apply a shearing force right here. And then this will, if it reproduces the patient's pain on her ulnar side that she was complaining of, then it would be positive. Another way to see if our patient's TFCC is contributing to ulnar-sided pain is by the wrist-hand press, also known as the sit-to-stand test. So how I'm going to cue my patient to do this is I'll ask her to sit in this position with her hands by her side, with her hands flat on the armrest. I'm going to ask her to try to stand up, but to use her arms and really drive through her hands flat like so. And if that reproduces her ulnar-sided complaints of pain, then it would be positive. So if our patient has ulnar-sided complaints of pain and we want to check to see if there's compromise of the TFCC, then we can do the supination lift test. So I could provide manual resistance right here and push down as my patient lifts up, but we were taught a better way to do that is to have our patient come under the table, and again making contact with about right here. We're going to ask my patient to lift up the table as best as she can, and as she does that, we're looking to see if that reproduces the pain on her ulnar side, and if so, it would be positive. All right, so if my patient has ulnar-sided wrist pain, then we can check for the TFCC with the ulnar impaction test. So what I'll do is I'll have my patient sitting here with her, and she's in elbow flexion, and I'm going to secure her forearm. And now I'm going to take my hand and then secure her fourth and fifth metacarpals, bring her into ulnar deviation, and actually load her like so. And then if that reproduces her ulnar-sided pain she came here for, then it would be positive. And then if it doesn't, then we can also do the TFCC load test. So in this position, we'll go into wrist flexion and extension, maintaining that ulnar deviation and the axial loading, kind of like a Scouter's test. And if that's positive, or if that reproduced her ulnar-sided pain, then it would be positive. This is the Bunnell-Littler test, is to see if motion restriction in the fingers is from joint problems or muscle problems. So what we'll do is I'll have my patient with her MCP right here, and it's going to be in relative neutral, so it's not in a flexed position. Now I'm going to passively take her PIP through a range of motion, looking to find where the restriction is at. And now I'm going to passively flex her MCP, again, and now I'm going to retake the passive range of motion of the PIP. And then in her case, she has an increased range of motion, so if she had motion restriction, it would be from the muscle. But if there was no change in motion when her MCP is flexed, then it would be for joint reasons at the PIP. Alright, so this is the Hansen-Coley test. It is this test to see if the DIP flexion is from the oblique retinacular ligaments or if it's from the joint itself. And so we're going to do this by much similar to the Bunnell-Littler test, where we have our patient's PIP in neutral, so it's not in flexion. And now what I'm going to do is I'm going to passively move her DIP through range of motion, keeping that PIP still. When noting where I feel that restriction, now I'm going to move her PIP into some flexion, and again I'm going to move her DIP into flexion as well, looking to see if there's a difference. And so if there's an increase in range of motion when her PIP is flexed, then it would be from the oblique retinacular ligaments. But if there is no increase in motion when her PIP is flexed, then it would be from a problem at the joint of the DIP. Alright, so this is the Finkelstein test. It's if we're suspecting de Quervain syndrome, then this is a test that we should do to rule this pathology in or out. So what I'm going to do is I have my patient with her elbow extended right here with her thumb up. Now I'm going to ask her to make a fist with her thumb inside, still having her thumb side up so her snuff box is the most superior part. Now I'm going to bring her through ulnar deviation, looking to see if that reproduces the pain around her snuff box, and if so, then it would be a positive test. So we're going to do the FDP and the FDS test. So we'll start with the FDS test. So I'll have my patient here, and I'm going to block everything other than the PIP joint on my patient's finger, and then I'll ask her to raise her finger towards her, and then I can double check this by flicking her DIP to see that it's not contracting. And now we can do the FDP test. So what I'm going to do is I'll block everything except her DIP and ask her to raise her finger like so. And since I can see the tip of her finger moving while blocking everything else, then I know that that would be intact. Integrity of extensor hood test. What we're going to do is we'll have our patient with her palm facing down right here, and then she's going to have her fingers over the edge of the table, specifically at her PIP joint. And now I'll put pressure on her mandible phalanx right here, and I'll ask her to extend her fingers up, looking for activation of those muscles. And if I feel activation of her extension in her fingers, then it would be a negative test. But if there is no activation of extension in her fingers against me, then it would indicate that there's loss of integrity of the central lip, so the extensor hood is there. Alright, so if we're suspecting that our patient has carpal tunnel syndrome, we can test that with a few tests right here. So the first one is going to be the phalanx test, where we're holding our arms like this. So we'll be in shoulder abduction, elbow flexion, and then we'll have our wrist inflection. And we'll hold this for 1 minute, looking to see if we produce the numbness, tingling, or paresthesia along the median nerve. Looks like Sam might have that. And then we'll go into the reverse phalanx test, which is kind of like the opposite. So it looks like we're in a prayer position. So now our wrists are in extension. And again, we'll hold this for a minute to see if it reproduces the numbness, tingling, paresthesia along her median nerve. And then if she has enough shoulder elevation like Sam does, then we'll go into the hand elevation test. So she'll hold her arms up like a ballerina with her wrist flexed. And this one we can hold up to 3 minutes, looking again for the numbness, tingling, and paresthesia along the median nerve. If those symptoms come up in any of those tests, then that test would be positive. Two other tests that we can do to test for carpal tunnel syndrome: the carpal compression test and the Tunnell sign at the wrist. So for the carpal compression test, we'll take our thumbs, dummy thumb it at the median nerve at the wrist, and then we'll hold it for up to 30 seconds, looking to reproduce the numbness, tingling, or paresthesia along the medial nerve distribution on the palmar side of her hand. If that reproduces that numbing, paresthesia, and loss of sensation, then it will be a positive test. Then another one we can do is the Tinel sign. So again, we'll do the quick tapping of the median nerve, again looking to see if we reproduce the numbness, tingling, and paresthesia along the median nerve distribution of her hand. And if so, that would be positive. Alright, so if we want to see if there's an ulnar nerve lesion in our patient, then we can do the Frohman sign, because the ulnar nerve controls a deduction of the thumb. So I'll ask my patient to hold this index card in between her thumb and her index finger, and to not let me pull it out of her hand, but in doing so to keep her thumb nice and straight and to not bend anywhere else in her hand. So when I pull the index card like so, right now Sam is negative because she's not doing any compromise. But what would be a positive test is if there's flexion in her IP joint, because that would mean that she doesn't have enough adduction strength to control, or she's not being able to adduct to hold the index card in place, so she's having to compensate with other motions. This is the Allen test, and we're going to do this to test for vascularization of our patient's wrist and hand. So what we're going to do is I'm going to find the radial and ulnar arteries right here. I'll ask my patient to give me 5 big hand squeezes, and on the 5th one to hold it. Now I'll squeeze on those arteries, and I'll ask her to slowly open her hand. First I let go of the ulnar artery, and I see her hand restore its color. Normal is within 5 seconds, and I'm like, okay patient, now we're going to do the same thing. Again, I add the pressure, ask her to slowly open her hand. Now I let go of the radial artery first, and she restored her color. And then when I'm doing this test, I'm looking to see if there's any side-to-side differences, looking to see like if the filling time between the radial and the ulnar artery is different from each other. And then obviously I want the whole hand to refill within 5 seconds.